Hey guys, welcome to Man Medicine, where we talk about how men can optimize their health and escape the collapsing U.S. healthcare system. Well, I've been away for a few days. I've been pulling some ER shifts. One of the things I see on almost every single ER shift is some sort of skin and soft tissue infection. I usually see multiple skin and soft tissue infections actually per day in the area that I work. And so that's what I want to talk about with you guys today, but specifically as it relates to the use of underground anabolics. I know a lot of you guys do the right thing and you get your testosterone from an approved pharmacy, you got a legitimate prescription from a doctor, but I also know a lot of you guys use underground sources for whatever reason. So this is something that you need to know a little bit about, something that you need to be aware of. And I want to show you some of the literature out there and talk a little bit about how, as doctors, how we manage these types of infections and what you can do if you think that you may be developing one. Okay, so this is a case study I want to show you guys out of Israel. So this is from the Department of Plastic and Reconstructive Surgery, Tel Aviv Soraski Medical Center in Tel Aviv University, Israel, published in June of 2016. And the title is Bodybuilder's Nightmare, Black Market Steroid Injection Gone Wrong, a Case Report. So I'm just gonna read the case report to you guys, and I'll show you some photos of what this young guy looked like and then his course over time and how things, thankfully for him, he ended up surviving this and ended up okay, but things absolutely could have gone sideways in this case for him. He's actually, in my opinion, was lucky to have survived this, because I have seen things like this, not in steroid users, because that's not a common presentation to the emergency department, but definitely in IV drug users. I see a lot of that, and sometimes those don't always end up well. So there's some major complications, which we'll talk about here in a second. Okay, so this case. So this is a 35-year-old healthy male. He said he was referred to our emergency room by his physician because of painful skin necrosis over the left buttocks, approximately 5 by 4 centimeters, and painful skin necrosis with purulent discharge. So that means it was actively discharging pus, which is a sign generally of a deep space infection, like an abscess. So it was actually spontaneously draining, which may have been one of the things that saved this kid. So on the right, this is a picture here. This is the initial visit in the clinic. So this is where this guy injected both sides. You can see really big tissue defects here with black necrotic tissue. So this is all dead tissue here. You can see some of this yellowish material here is likely pus and other necrotic debris. These are both very serious infections on bilateral glutes on this kid. So the patient, so I mentioned he's a 35-year-old previously healthy man. He said he's just a recreational bodybuilder, uses illicit substances to rapidly gain muscle. He has been using testosterone and various anabolic steroids for the past 4 years, and 3 weeks before his referral, changed his regimen to include a new steroid. What do you guys think it was? It was Trenbolone. So these are from Trenbolone injections. He recalled feeling pain upon injection, which led him to inject more slowly and in an alternating pattern to both gluteus maximus muscles. The patient recalled persistent tenderness and induration of the injection sites, followed by, quote, darkening of the skin, close quote, extreme pain, and secretion, so presumably the purulent discharge. So they didn't mention what the volume of injection was. So I don't really know how many cc's this guy put on each side, but it was an immediately painful injection, which should be a bit of a red flag in and of itself. Enough so that he felt he probably needed to cut the volume in half and put half in one glute and half in the other. But he had immediate pain, immediate discomfort, and immediate darkening of the skin, which is a red flag, which we'll talk about here in just a second. So this is what he looked like when he presented to the plastic surgery clinic, so not to the emergency department. A little bit more history. The patient was prescribed a course of a first-generation cephalosporin. So in this case, it was actually cephalexin, or brand name Keflex. and followed by a course of amoxicillin and clavulanic acid, which is brand name is Augmentin, by his physician with no improvement, and thereafter was referred to our center. In the plastic and reconstructive surgery department, he underwent surgical wound debridement. The necrosis seemed to involve the skin, subcutaneous fat, and a small portion of the gluteus maximus muscle. So this is full thickness all the way down into the muscle. So he's very lucky that it didn't also invade into the muscle, and that he's also lucky that he didn't become septic and die of a systemic infection from this, because that very easily could have happened. And here's the interesting part. Wound cultures were positive for Staphylococcus aureus, so Staph aureus. So Staph aureus is, I'm not going to go into a full microbiology lecture for you guys. I will spare you that. Staph aureus is a particularly bad actor in a number of different infections, but especially in skin and soft tissue infections, it is particularly nasty. There are many species of staph. This is what Staph aureus looks like when in something called a gram stain under the microscope. So it's these kind of clusters of these circular purplish little bacteria, and they cluster together. And this is how you differentiate it from like Streptococcus species, because those cluster in a slightly different, kind of more of a linear pattern. But this Staph aureus is particularly nasty. There are other species of staph. Many of them will cause infection, but a lot of them don't. A lot of them just will live on your skin, and you know, as long as you have a healthy immune system and you're not compromised, generally don't cause any problems. You know, if you're immunocompromised, if situations change, then yeah, sometimes those can be a problem, but generally they are not. So Staph aureus is the big bad one. There's something called Staph epidermidis, which is, you can probably guess from the name, that lives on your skin, and again, it generally doesn't cause problems unless maybe you're an IV drug user, maybe you've got a mechanical heart valve, maybe you know, you've got some immune compromise, you've got other issues going on. What else? There's Staph saprophyticus. I see that with kind of uncomplicated urinary tract infections every now and then. So the staph species can cause a lot of problems in a lot of different areas, but Staph aureus is the one particularly that I deal with on an almost daily basis with these skin and soft tissue infections. Streptococcal bacteria obviously play a big role in that too, but Staph aureus is the one that really produces a lot of pus. And it does that because it creates all of these particularly toxic enzymes and bacteriotoxins that are designed to help it survive in the body and help it defeat your immune system. So it produces something called a coagulase, which converts fibrinogen into fibrin, and then that sort of walls it off from the white blood cells in your body that are going in to try to kill it. There's an exfoliative toxin, which is particularly nasty, and it produces a syndrome called staph scalded skin syndrome, which I've seen one time in my career. This is actually a picture of it, what it looks like here. Your skin just basically, it looks like somebody has burned you, or you have a severe sunburn and your skin is just peeling off. Very, very serious, you know, type of infection. And that's kind of that's a classic photo of that condition. There's something called a DNase that breaks down your DNA, and then a catalase, which inactivates hydrogen peroxide. So your white blood cells will use hydrogen peroxide that they generate themselves in order to kill the staph. Then the staph has this catalase enzyme, which, you know, inhibits that or breaks it down. So it's this battle between the staph and your immune system, and you know, there's different tactics that both sides use to win that little war. So, but you know, the point is that this is a particularly nasty bacteria. Now, the antibiotics that this guy's initial doctor in the emergency room chose these were poor choices for what this guy had. So he chose a first-generation cephalosporin, and again, it was cephalexin in the paper, and then went on to Augmentin, which is amoxicillin and clavulanic acid. So for a regular cellulitis, which I'm going to show you guys what that is, which is just a superficial infection of the skin, you know, those are not unreasonable choices in an otherwise healthy person. They're not systemically ill. They're not septic. It's not unreasonable to try those, you know, one or those two. I wouldn't use Augmentin because it's probably overkill, but cephalexin's not a bad choice. You know, I do prescribe a fair amount of that for routine, you know, skin infections. But if you have a deep space infection, if you have an abscess in particular, and in particular if you're worried about Staph aureus, there's a particular type of staph called MRSA, MRSA, methicillin-resistant Staph aureus, which I'll talk about here in just a second. Those strains are completely immune to those two class of drugs. So they're immune to all penicillins and certainly immune to all cephalosporins, especially first-generation cephalosporins. It just laughs at those. So it has evolved a number of defensive mechanisms that make those antibiotics ineffective. So those two were that was a poor choice on that doctor's part. So he really should not have prescribed those. As we'll talk about here in a second, if you have a deeper space infection, if you have an abscess, absolutely, antibiotics, can help with that, but the treatment is surgical. It's drainage. So I drain pus every single day in the emergency department because I know I can give these people antibiotics, but they've got a fluid collection that's walled off, and I'll show you what that looks like here in a second. The antibiotics are not going to get in there. They're not going to solve that person's problem, and they're probably it might keep it at bay for a little while, but they're ultimately going to get worse. So this young guy should have been put on broader spectrum coverage that will cover MRSA, will cover other types of bacteria as well, and he should have either had an incision and drainage in the emergency department or referred directly to a general surgeon that day. And it sounds like there was a bit of a delay, so luckily he survived and he did okay with this. So these are some photos of his course over several weeks. So this first one, this is after 3 weeks. So ambulatory follow-up, meaning in the clinic, it looks like it's healing really well. So all that necrotic tissue, they cleaned all of that out, and they've been doing dressing changes, and they were letting this wound fill in by secondary intention, meaning healing in from the bottom. So when I look at this wound, you can see what that red tissue there, that's what you want to see. That's very, very healthy looking, what they call granulation tissue. It's nice and red. That means it's got a good blood supply to it, and it's healing in from the bottom. And then as it heals in from the bottom, the skin is going to slowly come in to close over that wound. And clearly he's going to be left with a couple of gnarly scars, which is what you see here. This is complete epithelialization, meaning the skin has grown over it. It looks like at 2 months. So he's been left with this, two pretty nasty looking scars here with some post-infection, post-inflammatory, looks like hyperpigmentation where the skin is going to be permanently darkened in that area. And that's from injecting tren, which all tren, by the way, as I'm sure you guys are well aware, there's no legitimate pharmaceutical sources for tren these days. That it's considered a veterinary agent, typically used with pellets. So if you're using tren, first of all, it might not actually be tren, and we'll talk about that in a second, but it almost always is coming from an underground lab. It's not meant for human use. So correct me if I'm wrong on that, you guys that are the steroid gurus out there, but as far as I know, there's no actual legitimate pharma human-grade trenbolone in existence. Okay, let's talk just briefly about MRSA, methicillin-resistant Staph aureus. Why do we have MRSA? Well, it's because of bad doctors, and it's because of patients using and requesting antibiotics when they don't need them. So over the years, there's been massive overuse of antibiotics to treat viral infections. So when you come in with a snotty nose and you think you have a quote sinus infection and you need antibiotics for that, the odds are overwhelming that you don't. But your doctor sometimes, because they don't want to have that fight, or because sometimes they don't know any better, will throw some antibiotics at you. And the fact of the matter is they're generally not doing you any favors when they do that. So over the many decades, the bacteria have gotten smart, and they've learned they develop mutations that allow them to survive in an antibiotic-rich environment. So and there's two different strains generally of MRSA. So there's community-acquired MRSA, which is probably what this guy had. They didn't mention it specifically, but probably had community-acquired MRSA. And then there's the MRSA that you get in the hospital, which is usually the nastier version. And the bugs that you get in the hospital always tend to be a bit more virulent, a bit nastier, and a lot more resistant to multiple antibiotics than bacteria that you might acquire out in the community. So, you got to be careful. Hospitals are dangerous places. So, fortunately, there's still a handful of antibiotics that tend to work, reasonably well for community-acquired MRSA, but the susceptibilities vary. Like at my hospital, and every hospital really has something called an antibiogram, which is they test all of the cultures that come through the emergency departments and the clinics and the ICUs, and then they test them against various antibiotics, and they'll tell you, the MRSA at your hospital is susceptible to clindamycin, doxycycline, and rifampin. It's resistant to all penicillins, all cephalosporins, and it has intermediate resistance to, whatever, so, throw in some other antibiotic. And that might be slightly different than the Staph aureus that you would get at a hospital on the other side of the country or on the other side of the world. So there's some variation there. But generally, clindamycin, doxycycline, trimethoprim sulfa, rifampin, linezolid, like those are oral antibiotics that still have some efficacy for community-acquired MRSA. But I mean, as time goes on, we're going to overuse these antibiotics too, and the staff will adapt, and we're going to have to come up with some new antibiotics because these bacteria, they do adapt to this kind of stuff. So it's an arms race, right? It's one side gets a new weapon, the other guy's got to have a defense to it, back and forth, and that's how this starts. So the take-home lesson, I guess, from that, there's probably many take-home lessons from this, but one of them is just try to avoid antibiotics unless you really need them. Don't go to your doctor. Every time you have a sniffle, I don't care if you have yellow snot, it doesn't matter. There's no correlation between having yellow or green mucus and having a bacterial sinus infection. You don't need antibiotics for that. Try not to expose your body to antibiotics unless you really need them, because this is a problem. This is why we have MRSA. Here's another interesting thing, and I actually was not aware of this, but it kind of makes sense. So, a lot of the bacteria that cause skin and soft tissue infections, in many cases, are bacteria that they just live on your skin and they don't cause any problem. But there's a break in the skin, an IV drug user pops a needle through there. Obviously, the needle might not be clean, and that's a problem too. But it turns out bodybuilders that use anabolic steroids have slightly different skin flora, meaning skin bacteria. They tend to have more skin bacteria than non-anabolic steroid using athletes, and also just the lay public who obviously doesn't use anabolic steroids and doesn't exercise. So the prolonged use of anabolic steroids actually changes the bacteria that live on your skin. And this is a study here from Microbiology 2015 in January, the cutaneous bacterial microflora of the bodybuilders using anabolic androgenic steroids. And I thought that was kind of interesting. So what they showed basically is that in athletes in general, they tend to carry more Staph aureus than non-athletes, and anabolic steroid users actually had slightly more Staph aureus than non-anabolic steroid using athletes. So not a huge amount, but there was a difference there. And then there's this other bacteria called Propionibacterium acnes. So this is P. acnes. So this is a common bacteria that causes acne, and anabolic steroid using athletes have quite a bit more of this than non-anabolic steroid using athletes, and obviously much more than the control group. So that also probably explains why you tend to see acne flares a bit more in steroid users. It's not just the androgens, but it actually changes the skin flora that they have. So I thought that was pretty interesting, something that I was unaware of. So let's run through some of the ways that these skin and soft tissue infections can present. Let's say you do an injection and you end up with an infection. The most likely thing is something here is called cellulitis. So you're probably not going to be injecting in your lower leg, but this is how typical cellulitis. This is the kind of cellulitis that I see. So obese individual, probably a type 2 diabetic or pre-diabetic, and they end up with this very painful, hot, red, rapidly progressing skin rash. You can see somebody in the emergency department or clinic has outlined it there. And that's very helpful to see, so you can keep track of it. So sometimes these people are pretty sick, so they can present with a fever, but sometimes they're not, if you catch it early enough. And it's generally appropriate to treat these patients, assuming they're not systemically ill, meaning fever, low blood pressure, they're not getting septic on you, with just oral antibiotics. So the cephalexin would have probably worked on this patient. Now you don't always know for sure, but that's, all things being equal, a reasonable thing to do first line. It's like within the IDSA, which is Infectious Disease Society of America guidelines. So the thing you have to worry about is underneath that cellulitis, is there actually an abscess or a fluid collection? And sometimes you can feel it. It's pretty obvious. Sometimes there's actually pus, coming through like a break in the skin. But what I do almost universally, just to be sure, is I put an ultrasound probe like on that person's leg, and this is what I'm looking for here. So you can see on the left here, so this is what an abscess cavity looks like. So fluid is black on ultrasound. So here's this black like fluid collection in here, and then to the right of this is just cellulitis, or this might be something called a phlegmon, which is like an early abscess. It hasn't quite organized itself. Generally, if it's a phlegmon like this or just cellulitis, you can treat this with oral antibiotics. You don't have to cut it open and drain it. But that one on the left there, there's an obvious fluid collection there. That has to be drained. You can throw antibiotics on that all day long. It needs to be drained. And then this is something that I see every now and then. And this is a injection IV drug user related abscess, and this is from something called a pocket shot, which, you know, IV drug users, as many of you are probably aware, eventually they just destroy all their veins, all their peripheral veins, and so they have to get a bit creative in terms of where they can access a vein. And so some of them have gotten pretty good at doing what's called a pocket shot, which is injecting either the subclavian vein, the IJ vein, or there's a point there above the collarbone where the internal jugular and the subclavian vein meet together. And sometimes, especially if they're thin like this guy, most of the IV drug users I use, believe it or not, are not thin, so they probably can't access this. But if they're skinny like this guy, they can access that pocket. And this is what happens sometimes. Using, you know, improper technique and not unsterile needle, you don't clean the skin properly, and you end up with a big abscess like this. And this is a big problem because this is how you get things like endocarditis, and you get systemic infections as this bacteria, you know, you're putting it in a central vein. It goes straight to your heart, straight to your lungs. So it's a big problem. So this is the basics of what an incision and drainage of a skin abscess looks like. I do this every single day almost. So you have to open the skin up. You have to clean out all that pus, debris, and necrotic tissue. And then, you know, depending on the size of the abscess and what you're dealing with, a lot of times you'll pack it with sterile gauze, and you can see it filling in from the bottom there. A lot of times you don't have to do that, or you can do something called a loop technique where you put a kind of a rubber band through one end and out the other, and that just keeps it open so that as it heals in from the bottom, if there's any residual material that develops in there, it'll drain, and they tend to do pretty well with that. But you got to drain these. You can't antibiotic your way out of treating an abscess in most cases. Once you've developed this fluid collection, it needs to be drained. So which usually means you got to come to see me in the emergency department. Maybe your doctor can do it for you in the clinic, but these days they usually just send them over to the emergency department. Okay, the thing I really worry about, and I have seen on a handful of occasions, is necrotizing fasciitis, and you guys may know this as flesh-eating bacteria. So you cannot, if you catch, you have to catch this early. If you catch it late, like in these two pictures here, this is going to be more than likely, this is going to be rapidly fatal. So unfortunately, it a lot of times looks like regular cellulitis or an abscess to begin with. You have to kind of look a little bit deeper. You have to look at patients' vital signs, and a lot of times they'll have a lot more pain than you would expect. Like, you know, it may not look that bad from the outside, but you just touch this person or they just move a little bit and they have excruciating pain. It's because they have this rapidly traveling deep space infection. It's going into the muscle, it's going into the fascia, and I have seen this over the course of like literally 30 minutes march its way up somebody's leg. Like by multiple inches, it just goes. And those people, unless they get rapid resuscitation, powerful antibiotics, and get to the operating room ASAP, the mortality rate from this is through the roof. And most of the people that I've seen with this, I can think of maybe one or two that have survived, like full-blown necrotizing fasciitis. The rest have all died. And that's unfortunate. This is something that can happen from a dirty needle injection, especially an intramuscular injection, right? You can imagine, I mean, you're inoculating bacteria deep into the muscle and the fascia, and then it just takes off. It just takes off. And thankfully, it's rare. So if you look at the rates of these deep space necrotizing infections from an intramuscular injection, they're vanishingly low. But you know, you certainly can get a cellulitis and an abscess. So this is an article here out of the Department of Surgery, King Edward's Medical University, Mayo Hospital. When was this published? September 2014. Frequency and contributing factors in intramuscular injection abscess. So the good news is there's only 19 known cases of like necrotizing fasciitis from an intramuscular injection of, well, from any intramuscular injections, including testosterone. Now, truth is, there's actually 20, because I actually diagnosed one many, many years ago, and it was an elderly guy, late 60s, type 2 diabetic, not a well-controlled type 2 diabetic, and he injected testosterone like directly into the front part of his thigh. That's just what he did. And he did the standard 1 cc's every 2 weeks, like his urologist wanted him to do. And he came in with a hot red, probably, if I recall, probably 10 or 12 centimeter patch right on the anterior thigh that rapidly progressed out from his injection site, and it was rapidly progressing over like 8 to 12 hours. And every time I went to touch this guy's leg, or any time I even tried to bend his knee, he just went through the roof. And then I noticed, his heart rate was up a little bit. He had abnormal vital signs, and his blood pressure was a little bit soft. Anyway, long story short, the surgeons didn't believe me. I said, hey, I got a guy here, did an IM injection of testosterone, and I think he's got necrotizing fasciitis. And they said, no, he doesn't, over the phone. So I was actually forced to get an MRI on this guy. And thank God I worked at a big center at the time that I could get an MRI like within 10 minutes. So off he went. I put him on, broad spectrum antibiotics. Sure as shit, he gets in the MRI scanner and he's got this deep, like rapidly spreading infection through the muscle, through the fascia. And he went off into the OR and he lost like a quarter of his quad as a result of that, but he did survive. So, thankfully those kind of infections from an intramuscular injection, whether it's testosterone or anything else, thankfully very rare. But they're not. It's not rare to get skin infections, and it's not rare to get localized abscesses. So something to be aware of. So what are the things that put you at risk for getting an abscess when you do an intramuscular injection? Well, this is the chart from that paper. So number 5, the biggest one here is just, they say, improper sterilization of the site. So basically people that don't clean the skin, they don't clean the top of the bottle with an alcohol wipe. If you take, roughly 5 minutes and clean the site where you're going to, even if you just wipe with an alcohol wipe, you've done a lot there. You've probably taken down 70 to 80% of the skin flora at that site, and you're using a sterile needle, and you're obviously using good pharma grade source for your TRT. The chances of you getting an infection are extraordinarily low. But I've got a good friend of mine who's had at least 2 bouts of cellulitis from a perfectly done subcutaneous testosterone injection. So these things, they do happen. And especially if you're colonized with MRSA or any of these like particularly virulent skin flora, then yeah, you're a little bit more likely to get to get an infection. But thankfully, even those cases are pretty rare. So factor 4, I like this one a lot. They just say quack. Now, what they mean by that is someone who's untrained at giving injections. So your bro at the fraternity dorm injects your tren, and he doesn't know what the hell he's doing, and maybe he's a little bit drunk. And so he's not going to do a good job. So having somebody inject you or injecting yourself, if you don't know what you're doing, clearly is going to up the risk of an infection. It's going to up the risk of all sorts of complications. So learn how to do this. If you do your own injections, it's not hard. And if you have somebody else do it, just make sure that they're properly trained. Factor number 3, right up there, in 60% of these cases, is diabetes. Okay, both type 1 and type 2. So just like the guy that I saw with the quad infection, yeah, diabetes absolutely increases your risk. Both diabetes and prediabetes definitely ups your risk for these skin and soft tissue infections. I see it all day long. In fact, I think it's fair to say the majority of skin and soft tissue infections that I see are in people who are either diabetic or pre-diabetic. Yeah, I think that's a fair statement. Factor number 2, associated closely with factor number 3, is obesity. Absolutely. And then finally, this is the lowest one because very few people do this, but unsterilized syringes. I hope it goes without saying that you guys don't do that. But there are certain parts of the world where syringes get reused, and because they're not readily available, and attempts might be made to sterilize them that are inadequate. So yeah. And maybe in third world countries this is more of an issue, but not generally an issue in the TRT community, thank God. So, okay, this guy was using trenbolone. Clearly, this is a black market drug. There's not a lot of data on analysis of counterfeit steroids when it comes to the sterility. So there's quite a few studies, and this is one of them here that I'm going to show you, that talk about, does the product contain what's on the label? And big surprise, like a lot of these products do not contain what's on the label. So this particular article here, Drug Testing and Analysis, Counterfeiting in Performance and Image Enhancing Drugs. So yeah, they took 38 confiscated vials of various performance enhancing drugs, all of which were either anabolic steroids. I think they had some like thyroid preparations in here too. But as far as containing what they stated on the label, of the 38, only 18 of them had what was actually on the label. 8 of them were contaminated with other steroids at various doses, and 12 of them had no active ingredients whatsoever. What caught my attention was that the majority of these, of the 38, they cultured it on a petri dish, and they were not sterile. So they contained, what grew out was what they said was normal skin flora. So those are bugs like Staph epidermidis. So Staph aureus is not technically normal skin flora, but about 40% of people run around with Staph, either MRSA or non-MRSA Staph aureus species on their skin. A lot of it's in your nose, so it resides in the nares on both sides. So Streptococcus pyogenes, which is a source of infection, Strep mitis, Acinetobacter, and then Pseudomonas is not typical skin flora in healthy people, but it can be in people who are immunocompromised or who've had a lot of antibiotic exposure over the years. So, yeah, so just keep this in mind. I mean, when you're getting your underground lab tren or testosterone or whatever the case may be, it's probably not completely sterile. And that doesn't mean you're necessarily going to get an infection every single time. But what this tells me, the fact that it has skin flora in it, I think we can make some assumptions that whoever was making these particular products, was touching them with their fingers without a glove, probably. So maybe they, the tubing that they used, or they were touching the vial with an ungloved hand, presumably. And so bacteria from these people's skin or from their nose was getting into the finished product. And, I don't think it takes a rocket surgeon to realize that injecting stuff like this, especially if you're injecting large volumes, so more than 1 cc at a time, which again most bodybuilders are doing that, the more bacterial load that you inject into a space in the body, whether it's subcutaneous or intramuscular, the more likely you are to establish an infection in that area. So that kind of surprised me, but yeah, these products, do not count on them being sterile. Okay, so buyer beware, buyer beware. So that's all I have for you guys today. Again, I just saw a lot of these over the last week, so I thought I'd do a little video on these. If you choose to use underground gear, just understand that you are taking a risk, and if you start having any signs of an infection, redness, pain, swelling, especially if you're getting like purplish discoloration in the central part of the area that's red, especially if it's shortly after you injected, just come to the emergency room. I don't have a problem, giving you guys that advice. I usually try to keep people out of the emergency department, but you don't want to end up like the guy in this case study with 2 big necrotic areas out of your glute. You don't want to end up like these people that have necrotizing fasciitis, or ended up having to be admitted to the hospital because they've got bacteria in their blood that has seeded other parts of their body, like a heart valve, etc. So just don't take any chances is all I'm saying. All right, guys, if you have experience with this, if you've ever gotten an infection either from legitimate pharmaceutical products or from underground labs, I'd love to hear what your experience is. Don't try to treat these on your own. Just come in and see a medical professional. That's what we're here for. We do this kind of stuff all day long in the emergency department, and it's better to get it taken care of before it gets too far. All right, guys, I'll catch you next time. Bye.
All Man Medicine video and audio has been created and shared online for informational purposes only. This podcast does not constitute the practice of medicine or professional healthcare services of any kind, including the giving of medical advice. I am not your doctor. No doctor-patient relationship has been established. This content is not meant to be a substitute for professional medical advice and should not be relied upon solely for that purpose either. The only purpose of this content is to present peer-reviewed, research-backed health information for your consideration. As always, rely on the advice and guidance of your personal physician before undertaking any activity presented here, and if in doubt or not comfortable with said activity, practice discretion. Your health is your responsibility and not ours. Finally, I take conflicts of interest seriously. I accept no compensation whatsoever from any private corporations, including pharmaceutical or supplement companies. You can trust that if I recommend a medication, product, or service, it's because I genuinely believe in it and not because I'm being paid to endorse it.